Let's talk about splenomegaly. Spleen is situated in left upper quadrant. It lies behind 9th, 10th and 11th ribs, and its long axis situated in 10th rib. It attached to stomach via gastrorenal ligament, which is also called gastrosplenic ligament, and kidney via linorenal ligament, which is also called splenorenal ligament. Spleen contains two types of cell. One is red pulp, one is white pulp. This red pulp used in removal of defective and sense RBCs, and white pulp used in synthesis of antibody. Other actions of spleens are removal of antibody-coated bacteria and blood cells, and it acts as a hematopoietic organ where blood synthesis from bone marrow is depressed, like aplastic anemia. Now let's see what are the complaints patient may have when he develops splenomegaly. First, patient may have complaint of pain and heavy sensation in left upper quadrant where spleen is generally situated. Patients also may complain of early satiety, which is due to compression of stomach. It is generally seen in massive splenomegaly patients. Patient may also complain of severe pain. It is due to vaso-occlusion and infarction. It is generally seen in children with sickle cell crisis. Patients also developed intraperitoneal bleeding, shock and death, which is seen due to rupture of spleen, which is generally seen in massive splenomegaly. Now comes very important part. This is clinical examination. The first step in clinical examination is inspection, thorough inspection of the patients. In inspection, we may find fullness in a left upper quadrant where spleen is situated. There may be sign of causative disease, like for CLD, it may be jaundice. The most important part of clinical examination in splenomegaly, it is palpation. Traditionally, what we do, we flex the knee of the patients to relax the abdomen, and we palpate spleen from right iliac fossa to left costal margins. Generally, spleen is enlarged from left upper quadrant to right iliac fossa. Its middle enlargement is limited by phrenicocholic ligament. Its inferior enlargement is limited by linorenal ligament. If there is no splenomegaly in traditional method, then we can go for hooking method, which is also known as Middleton maneuver. Here we stand in the left side of patients and insert our both hands in left costal margins and feel for the spleen. After palpation, the second most important is percussion, but palpation is more reliable than percussions. In Harrison, they mentions three methods for spleen percussion. First is Trop's semilunar place, second Nixon's method, and third is Chester's method. Trop semilunar space is bounded by superiorly by 6 intercostal space, laterally by a left anterior axillary line, and inferiorly by costal margins. If any dullness present on percussion of trough space, then it indicates splenomegaly. Splenomegaly may be mild, may be moderate, may be massive. It's depending upon the enlargement of spleen from left costal margins. If it is less than 5 cm, then it is mild. If between 5 to 8 cm, then moderate. But if the length is more than 8 cm, then it's called massive splenomegaly. Now let's see various causes of splenomegaly. Mild splenomegaly may be due to enteric fever, malaria, infectious mononucleosis, and infective endocarditis. Malaria may cause mild, moderate, or severe splenomegaly. Moderate splenomegaly is generally due to portal hypertension, hemolytic anemia, and amyloidosis. And massive splenomegaly may be due to CML, Kala-Azar, lymphoma, Koch's disease, and polycythemia vera. In Harrison also, they mentioned causes of massive splenomegaly. Those include CML, lymphoma, hairy cell leukemia, polycythemia vera, sarcoidosis, Gaucher's disease, and diffuse splenic hemangiomas. If patient present with severe pain along with splenomegaly, then it may be due to splenic rupture, splenic abscess, or infarction, which is generally seen in sickle cell crisis. One of the important thing is splenomegaly is to differentiate splenomegaly from enlargement of kidney. Generally, in splenomegaly, spleen is smooth and regular, but it may not be smooth and regular in enlargement of kidney when the enlargement is occur due to polycystic kidney disease. Generally, spleen is moved with respiration, but kidney, because it is a retroperitoneal structure, it's not moved with respiration. Get over the swelling is not possible in splenomegaly because it's extend up to costal margins. But get over the swelling is possible in enlargement of kidney. Splenic notch is present in splenomegaly, but in enlargement of kidney, this notch is not present. In splenomegaly, it is always a unilateral enlargement, but in renomegaly or enlargement of kidney, it may be bilateral.